Hello, everyone. I would like to start by thanking the biomechanics section of the Portuguese Orthopaedics and Traumatology Society for this kind of invitation to talk a little bit about shoulder instability and how it goes way beyond the glenohumeral dislocation concept. So when we approach a shoulder patient, we have to have in mind that the shoulder is not just a glenohumeral joint. The shoulder is a group of joints. It's an articular complex that, if you take into account the subacromial joint, it has 5 joints. These joints have all to work together for the shoulder to have an harmonious movement, and they are all very important for shoulder function. Another thing that we have to take into account is the intimate relationship between the shoulder and the thorax and the axial musculoskeletal system. So a third thing that is very important to acknowledge when you treat a shoulder patient is that the rotator cuff, it's not just the rotator cuff humeral insertion. It's not just the tendons that insert in the humeral head. The rotator cuff, it's a group of muscles that come from the scapula, they insert on the scapula, and they go towards the humerus, embracing the humeral head and stabilizing it. So it is very important for them to maintain their correct vectors and the correct function, the position that the scapula has towards the humerus or in relation to the humerus. So there are many muscles that participate in the movement of the scapula. Most of them are extra-articular, and you have to take them into account when you do a physical exam to your shoulder patients. One of them, and the most important one, maybe is the trapezius, that it's divided in 3 parts: superior, middle, and inferior, or upper, middle, and lower part of the trapezius, and that they act a little bit different from each other. A second one, and very important due to the role that it plays in the connection of the upper limb to our core, it's the Lat Dorsi. Another small muscle that is often neglected, but it's very, very important in the balance between retraction and protraction of our scapula. It's the serratus anterior. The deltoid is well known. It also participates a little bit in the movement of the scapula because it inserts on the acromion and alongside the scapular spine. And the last but not the least, a small muscle that inserts anteriorly, that's the pec minor, inserts on the coracoid process and participates on the protraction of our scapula. So these muscles are all very important to keep a good mobility of the scapula towards the humerus. So our ultimate goal in the shoulder girdle movement is to have a maximum movement with a minimum instability. So this means that we have to maintain all along the rotator cuff, the shoulder girdle range of motion. We have to maintain the glenohumeral center of rotation. And this can be done following 3 principles. So we have to have a correct horizontal and vertical glenohumeral force couples. We have to have a good scapulohumeral rhythm, and that's the scapular motion. That's what we're talking about. And third, the last but not the least, we have to have a correct kinetic chain. So let's go point by point. What are the force couples? Basically, the force couples are the agonist-antagonist mechanism that maintain the glenohumeral center of rotation, maintain the head of the humerus centered on the glenoid. So basically, for the shoulder to have a correct and physiological movement, the head of the humerus has to be inside this box. That's the vertical and horizontal stabilizers. So for example, in the vertical stability, you have the deltoid that pulls the head of the humerus up, and the superior rotator cuff and capsule that pushes the head of the humerus down. So you can have this movement. For example, when you have a rotator cuff tear or a capsular tear, you have a vertical instability. This can begin very small with a small tear and can progress to a rotator cuff arthropathy, for example. How about horizontal instability? Here you have agonist-antagonist forces between the anterior cuff and capsule and the posterior cuff and capsule. So they push the head of the humerus towards the center. When you have a capsular redundancy or a rotator cuff tear, and this is the most frequent one, is the anterior rotator cuff tear, like the anterior supraspinatus and the anterior subscapular, the scapular tendon, you have an imbalanced horizontal force couples. So you have a progressive loss of horizontal stability, and this ultimately leads to pain and dysfunction in the shoulder motion. So the second one was the scapular humeral rhythm. This is very important. As we've seen before, there are many scapular stabilizers, and they all contribute for a good and harmonious scapular movement towards the humerus. So the scapular retraction, protraction balance is also very important to maintain the rotator cuff vectors and to avoid the lesion. So as we've seen, this articular complex is composed by essentially 5 joints. They all, ones move more than others, but they are all very important, and they all play a role in rotator and in the shoulder girdle range of movement. So usually I compare the shoulder girdle movement with an Argentinian tango, because as you can see here, they need to move not only by themselves, but towards one another in an harmonious and coordinated, unimpinged movement and dance. So for this to happen, the scapular stabilizers have to be very coordinated. You cannot have an imbalance between retractors and protractors. When you do have an imbalance, what you have is a dancer that doesn't move and another dancer that does a lot of unnecessary movements, and this leads to impingement, this leads to pain, and this leads to lesion. So this is called the so-called scapular dyskinesis. So what is scapular dyskinesis, and how does it relate to shoulder injury? So scapular dyskinesis is not a synonym of the lesion of the long thoracic nerve or scapular winging. This can happen, of course, but the infinitely more frequent scapular dyskinesis is due to a muscular imbalance. So you have an inhibition of the retractor, the lower trapezius and the serratus anterior mainly, and an increased activation and a contraction of the protractors, like the pec minor and the upper trapezius. So this leads to a protracted and downward rotated scapula that clinically you can see it behaves like a winged scapula, where when you ask your patients to elevate or to abduct in the scapular plane, you see a proeminence of the medial border and the scapular angle. So why is this important? Because the rotator cuff works as a pulley. So here you have a schematic of a pulley. When you have an alteration of this shoulder rotator cuff vectors, you have an alteration of this limb of the pulley. And the more horizontal this limb is in relation to the pulley, the more force you have to do to uplift the same weight. So this increases a localized stress on our pulley, that is our rotator cuff. And we know that this leads to collagen, the loss of orientation of collagen fibers, metaplasia, or the loss of the transitional structure of the enthesis. The kinetic chain. The kinetic chain is very important. As we've seen before, there are a lot of muscles that connect our shoulder girdle to our axial musculoskeletal system. And why is this so important? Because our shoulder works as a crane. As you can see here, we need a stable core to have distal mobility without lesion. So here is our crane. When you have the basis of our crane is our core, you have the counterweight, that is the scapular stabilizers, and our upper limb is the crane itself. So we need to have a core that is able to generate an efficient intra-abdominal pressure that can support a mobility without lesion. So basically my final message to you is that when we approach a shoulder patient, we're always looking at the glenohumeral joint, the rotator cuff degenerative pathology. We clinically examine the glenohumeral joint. We do imaging on the glenohumeral joint, ultrasound, MRI, but we have to take a little dive and look for scapular dyskinesis and core weakness, because the great majority of the shoulder problems, mostly atraumatic instability or degenerative rotator cuff problems, can be solved with good rehabilitation. So thank you all for for the invitation again, and now see you in the discussion.